got 24 people now. I guess we can start. Good afternoon, everyone. Welcome to our January research seminar. It's my great honor to be as your moderator today. My name is Ziyue Wang. I'm a second-year PhD student at the Department of Family Medicine. And I'm also under supervision of Dr. Isabel Wendell and Dr. Howard Bergman, and also as a team member of ROSA. Before we start, I would like to read the land acknowledgement provided by McGill First Nations People's Home. McGill University is located on the land which has long served as a site of meeting and exchange among indigenous peoples, including the Haudenosaunee and Anishinaabe nations. McGill honors, recognize, and respect these nations as traditional stewards of land and waters on which we are meeting today. The care of people living with dementia is a WHO public health priority. People with dementia use health service twice as much as people without dementia. Interdisciplinary primary care, such as family practice groups and continuity of care with family physicians, have been proposed as a ideal approach to managing the growing and complex population of people with dementia. But the evidence of their effort is lacking, particularly in terms of equity of access to service. Through several Canadian and international research projects, the ROSA team, which means Research Organization of Healthcare Service for Alzheimer's, will present the current stage of knowledge on this burning and increasingly important issue on our aging society. It's my great pleasure to introduce our three speakers today. Dr. Isabel Wendell is Associate Professor of the Department of Family Medicine at McGill University and Health Service Researcher. She co-leads the ROSA team as a part of Canadian Consortium on Neurodegeneration in Aging. She's also an affiliate researcher at INSPQ, which is the National Institute of Public Health in Quebec. Dr. Nadia Syria is an assistant professor in the Department of Health Management, Evaluation and Policy of School of Public Health at the University of Montreal. Her research focused on the evaluation and optimization of interprofessional primary care teams for older adults. Dr. Claire Goddard-Sibriet is assistant professor at the Division of Geriatrics at the Department of Medicine at McGill University. She's also a geriatrician at McGill University Health Center. Her research focused on the care trajectory of people with major neurocognitive disorders, in particular how to prevent their potentially preventable hospitalizations. I would like to remind you that today's session will be 40 minutes to 45 minutes long, followed by 15 to 10 minutes discussion. You can raise your hands or post your questions in the chat, and this seminar will be recorded. So, Dr. Isabel Wendell, the floor is yours.
Thanks, Ziyue, for this really nice introduction, and thanks, Alexandra de Pocomandi and Francesca for organizing this very interesting seminars along the year. So today, it's my pleasure to be with you. It's my first time as a McGill seminar, so I'm a bit impressed. And so we will talk about how primary care, how can primary care help older persons with dementia and their caregivers. So we will go over a little bit of background, including the challenges in health and social care that experience persons living with dementia and their caregivers. And we will show a little bit what is our team about. And then Claire Goddard-Sibriet will show her research results on continuity of care with the family physician. And Nadia Suriol will talk about interprofessional primary care, and we'll conclude and show a little bit of future work if we have time. So what is the context? We know that we are living in an aging society, and in 15 years from now, 1 out of 4 Canadians will be 65 years old or older. And the healthcare system and the social care system need to adapt to this new reality and to provide adequate services and meet the needs of older adults in terms of patient care, appropriate and efficient and equitable care. And person living with dementia is a particularly very interesting population to study in this context, because there are the prevalence of dementia is really growing. And as you see on the graph on the right side, since 2000, there is an increase of 200% of person living with dementia in Quebec, and in some regions, in particular rural regions, it's even more. In the end, we expect that 1 out of 5 baby boomers will get dementia during their lives. So what is dementia? Dementia is an umbrella term that design a specific group of conditions that share a common set of symptoms. So for instance, change in memory, in particular, short-term memory, judgment, behavior, and so on. And Alzheimer's disease is the most common type of dementia, but there are other types like vascular dementia, Lewy body dementia, mixed dementia. So sometimes people say, oh, we cannot do anything for a person living with dementia, but there is no cure. But as it is the case for diabetes or other conditions with no specific cure, there are many things that we can do to support a person with dementia, to access appropriate services on time, and to live well as much as they can with dementia. In terms of challenges in health and social care for a person living with dementia and their caregiver, there are many of them, including that detection, diagnosis, treatment are often suboptimal. For instance, when a diagnosis of dementia is made, people living with dementia and their caregivers often share that they have no sense of hope about living with dementia. Sometimes they are said, oh, put your things in order and wait. And they need more supports following a diagnosis. It can be, at the same time, difficult for healthcare providers to manage the needs of persons living with dementia. For instance, to share a diagnosis of dementia, to disclose the diagnosis of dementia, it's not an easy task. So overall, our healthcare system, and you know that as well as myself, is sometimes fragmented with frequent transition and inadequate quality of care. And it's particularly the case for a person living with dementia who use twice the hospital services as other. There are many emergency department visits that are really needed. For instance, if they have a hip fracture, but some of emergency department visits can be avoided or prevented. So the optimal organization of healthcare system for a person living with dementia and their caregivers has been set as a priority by WHO and by Alzheimer's Disease International. So how can primary care help? We know that primary care is a way forward for a person living with dementia. So it's not a specialist disease, I would say, or other type of specialist disease. Persons with dementia, they present with a wide range of needs. On average, they have 3 other comorbidities like diabetes, hypertension, and so on. And they have different conditions like problems with their cognition, the caregiver needs the support, they have functional impairment in their daily lives. And the management of dementia relies less on medication and more on the integration on non-pharmacological therapies for a wide range of healthcare providers. So the family medicine groups are involved, the home care services are involved, OT, PT, social workers, and so on. And primary care is ideally positioned for the early detection, diagnosis, and person-centered management of dementia. So that's why we developed a research team on organization of healthcare services for Alzheimer's. And our team general objectives are really to evaluate not only the effect of public policy and organization of health services, but also the implementation of such policy and organization. We do that mainly in 5 provinces: Quebec, Ontario, New Brunswick, Alberta, and Saskatchewan, and as well internationally. And I'm currently in France, for instance. And we produce evidence for sure, but we always have in mind to have impact, and that our evidence will lead to appropriate actions to improve the healthcare system. So our objective for the next 3 years, and we will not cover them all today, I can reassure you, we will focus on the first one, which is access and continuity. So really understand how primary care help person living with dementia. We have other projects on the impact of COVID on person living with dementia. You know that the highest mortality rate was among person living with dementia in Canada. We are developing a learning, health, and social care system as well. And not only we produce evidence, but we really want to produce tools and activities that have an impact. So for instance, we have practical tools for person living with dementia and their caregivers and providers. For What with Dementia is the title of the project. It's an international project, and we have a multi-domain intervention about hearing and so on, physical exercise, the Delight project. So our team is composed of 11 principal investigators from the 4 universities in Quebec and beyond. We have 16 person living with dementia and care partners, caregivers as co-researchers with our team. 22 students in total, and highly qualified professionals. And we partner with the persons themselves, Alzheimer societies, the Ministry of Health and Social Services. So for instance, we are on the committee of the Ministry for Dementia, with Dementia Advocacy Canada and the College of Family Physicians of Canada. Just a little snapshot on how we engage person living with dementia and care partners. We engage them as it is stated by participatory research, from the development of research questions to writing articles. For instance, they changed completely our COVID project that we wrote without really involving them, because it was a 15 days turnaround to write the project. They completely changed our research question, and that was really nice. Our partners are from a diverse population, from rural or urban region, racialized, Anglophone, Francophone. They live in the community or in long-term care facilities. And we have really an individual and a group approach with them. We orient them, we prepare them for each meeting to make sure that they are fully engaged. And they participate in all research meetings. Sometimes they say, oh, I will not come to this biostatistic meeting, but I will come to the next one. So we work with an international committee from 9 countries, low income, middle income, and high income countries, with different countries for our project Forward with Dementia. We provided a report to help develop the national strategy on dementia with the Health Science Academy. And we lead some working group in the Canadian Consensus Conference on the diagnosis and treatment of dementia. So this is some nice pics, and we can see Marion was already in blue that day on your right. So now I will give the mic to Claire, who will explain her research project and results.
Thank you so much, Isabelle. So first, I'm going to focus on hospital use of older persons with dementia. So persons with dementia have twice the hospital use, emergency department visits, and hospital admission as older persons without dementia. This hospital use is associated with increased risk of delirium, falls, cognitive and functional decline, long-term care admission, and death. Some of this hospital use might be avoidable with appropriate ambulatory care. And for example, in the US, it's estimated that 20% of hospitalization of community dwelling persons with dementia are potentially avoidable. As we said, reducing avoidable hospital use and improving health services for persons with dementia are healthcare priorities. However, in Quebec and in Canada, there was no data on avoidable hospital use in community dwelling persons with dementia. So one of my objectives was to describe the prevalence and trends in potentially avoidable hospital use in community dwelling persons with dementia in Quebec. So I conducted a repeated yearly cohort study from 2000 to 2015 with data extracted from the Quebec Health Administrative Database. I included over 190,000 persons. I measured hospital use and avoidable hospitalization with 4 indicators. First, ambulatory care sensitive conditions with 2 definitions, general and older population definition. Ambulatory care sensitive conditions are a list of conditions which could be prevented or reduced with appropriate ambulatory care. The older population definition includes additional conditions that are more specific to an older population, like hypotension, skin ulcers, nutritional deficiency. Second, alternate level of care hospitalization, which corresponds to persons having completed the acute care phase of their treatment, but remaining in an acute care bed, mostly waiting for a long-term care admission. And finally, 30-day readmission after hospital discharge. During the year of diagnosis, I estimated in community dwelling persons with dementia that 60 per 100 person year had at least 1 emergency department visit, and that 40 had at least 1 hospitalization, with trends relatively constant over the 15 years. And an average of 47 days of hospitalization during the first year of diagnosis. To represent it in another way, for 100% newly diagnosed with dementia followed for 1 year, 60% had at least 1 emergency department visit, 40 had at least 1 hospitalization, of which on average and across the 15 years, around 25% would be potentially avoidable. So in conclusion, community dwelling persons with dementia have high hospital use, high avoidable hospital use, and there was a lack of improvement over the years. This was a comprehensive measure of the prevalence and trends of avoidable hospital use in community dwelling persons with dementia in Quebec. And we contributed to the development of the Quebec surveillance system of dementia and added 4 new indicators to the system. So then we interested ourselves in the impact of primary care continuity. By primary care continuity, I refer to the relational continuity, the relationship between the family physician and the patient that extends beyond specific episodes of illness. How would primary care continuity decrease avoidable hospital use? For example, by improving the management of chronic conditions, or improving the detection and treatment of acute exacerbations. The impact of primary care continuity on hospital use and avoidable hospital use in persons with dementia was unknown. So our objective was to measure the impact of primary care continuity on potentially avoidable hospital use in community dwelling persons with dementia in Quebec. I analyzed an observational cohort using inverse probability of treatment weighting using the propensity score. I'm going to come back in the next slide on this method. I included over 2,000 persons. 66% of them had high primary care continuity, and I measured the same outcome as I just presented you before. So how can I pretend that I did measure impact from observational data? As we know in non-randomized intervention, where some person, here the blue dots, were exposed to high primary care continuity, comparing the outcomes of the exposed and the unexposed leads to biased impact estimates. Indeed, exposed and unexposed might differ. For example, the person in high continuity group might have more diseases, which explains why they are so thoroughly followed. They might also have more visits to the emergency department. Simply measuring the difference in outcome between the exposed and the unexposed leads to the conclusion that persons having high continuity have more emergency department visits only because this association is confounded by comorbidity. Inverse probability weighting using the propensity score allows creating a weighted sample in which exposed and unexposed groups are comparable on measured baseline characteristics, especially on measured confounder. Under a set of other conditions, this allows strengthening impact estimation from observational data. So with this method in this study, I was able to show that if we were able to treat 23 community dwelling persons living with dementia with high primary care continuity, we would be able to prevent 1 emergency department visit. If we were able to treat 30% community dwelling persons with dementia during 1 year with high primary care continuity, we would be able to prevent 1 hospitalization. So in conclusion, we were able to show a negative, large, and statistically significant association between primary care continuity and hospital use. This was a robust estimation of an association between high primary care continuity and potentially avoidable hospital use. And we used methods allowing strengthening causal inference.
Thank you, Claire. It'll be my pleasure now to speak to you about another set of research that we've conducted within this ROSA team, which is looking at the impact of interprofessional primary care in persons living with dementia. So the objective of this project was to compare outcomes in persons living with dementia in Ontario, comparing those in interdisciplinary versus non-interdisciplinary primary care models, and look at how those 2 groups of patients differed in terms of their health service use. So what we did to conduct this comparison was to use health administrative data from ICES in Ontario, and similar to the methods that Claire presented, the data were repeated yearly independent cohorts of newly identified persons with dementia. And we looked over a period of 12 years from 2002 to 2014. And we took patients in 2 specific primary care models. We compared patients in family health teams, which are the equivalent of the GMFs here in Quebec, and comparing them to patients with dementia in family health organizations, which have the same physician characteristics, financing characteristics, the only difference being that family health teams have additional interprofessional primary care team members, whereas family health organizations are only group physician models. So this was allowing us to be able to hone in on the addition of interprofessional team members. We compared these 2 models of care on several outcomes, the primary outcome being the incidence of an emergency department visit in the year following their onset of dementia, The idea being that being able to have access to interdisciplinary care, the hypothesis being that those receiving this interprofessional approach should have better access to care and quality of care to be able to meet the varied needs that Isabelle presented well at the beginning of this presentation. So having access to this interdisciplinary approach should increase quality and access to care, which should have a downstream effect on reducing the need for ED use, which in the dementia population is often due to reasons that could have been managed in primary care. And then we also looked at other secondary outcomes, looking at non-urgent ED visits, hospitalizations, potentially avoidable hospitalizations, and 30-day readmission. I used the same causal inference approach that Claire so well explained in her presentation to be able to balance patients in family health teams and family health organizations on a number of confounders related to their socio-demographic characteristics, previous health service use characteristics, and other characteristics that were found through a participatory approach with our stakeholders to identify what are the factors that will lead to some patients being in one model of care or the other, and what are some of the factors that lead to patients with dementia seeking visits to the emergency department, in all an effort to be able to really extract an effect of belonging to an interprofessional primary care model. We also conducted a number of sensitivity analyses that I won't get into much detail in this presentation, but happy to discuss at the discussion period to look at the robustness of the results when we look at the impact of interprofessional care in different rurality settings. We also looked at augmenting the set of confounders in a subset of the data where we had a much richer set of data to work with, and looking at the impact of unmeasured confounding, which is how much could our results changed, would our conclusions have differed had there been a strong confounder that we didn't measure. So what we found in this study was counter to the original hypothesis. So the original hypothesis was that being part of an interprofessional primary care would lead to a decrease in emergency department visits. What we found instead was that persons living with dementia in Ontario in the first year after their date of diagnosis had an increase of 3% in their risk of visiting the ED. And when looking at their risk of having a non-urgent ED visit, we found an increased risk of 22%. In terms of hospitalization outcomes, results were not significant, and so inconclusive in terms of how the effective interprofessional care might influence hospitalization-related outcomes. So the conclusions from this study was that there was no decrease in overall ED visits, in fact, a marginal increase in ED visits, as well as a potential increase in non-ED visits. And so what might explain these counterintuitive results? One might be the fact that interprofessional primary care models, like in Ontario, did not have any targeted programs or efforts on a provincial level targeted to people with dementia. And so it could be that while they benefit from an interprofessional primary care model, they may still need more targeted efforts to affect change and curb avoidable health service use in this population. So these results really point to a need to better understand why and what are the reasons and pathways that lead to persons with dementia seeking ED. So it could be, on one hand, a positive effect to see an increase in ED use if, in fact, there is better awareness of symptoms in patients with dementia and interprofessional primary care models, and so are better able to know when they need to seek care in an urgent way. Or could it be the reverse, that being part of an interprofessional primary care team and seeing so many different providers might have in fact worsened fragmentation of care, led to confusion in this vulnerable population, and led to more ED visits. So while we see what the difference is, we need to also understand why. And so this is part of what we hope to be the next steps.
Thank you, Nadia. So in conclusion, because we want to keep time to discuss with you, I will be brief. So we are a team, Pan-Canadian and international team dedicated to health and social service research with a strong engagement of persons living with dementia, caregivers, decision makers, clinicians to improve research impact. So we not only produce evidence, but we also develop tools, recommendations. We have a learning healthcare system really to help this system to the needs of persons living with dementia and their caregivers. So as Claire and Nadia explained very well, persons living with dementia use a lot of emergency department and hospital services that could be avoided or prevented. The role of the regular family physician is absolutely key, and high continuity of care with the family physician is even more effective than many medications. 24 people, we need to treat 23 people for 1 year with high continuity of care to decrease one emergency department visit, which is absolutely very effective. But primary care physicians need to be supported well to do so, not only in terms of education and regular information about new evidence, interdisciplinary care, and as Nadia mentioned, we need to dig deeper to better understand how interdisciplinary care can better support persons living with dementia. Appropriate financial support as well for family physician and family medicine groups. But we have still a lot of work to do, and we are happy to have a lot of work to do because it's our raison d'être. And we have more results coming on the impact of COVID on persons living with dementia, both in the community and in long-term care settings. We are still waiting for the data in Quebec, but we have data in Ontario, Saskatchewan, and soon Alberta. I didn't show today that we did a lot of work on inequities in access to care and use of healthcare services by sex or gender, depending on the type of study, rural, urban areas, socioeconomic status, and racialized persons. And we are moving forward to implement learning healthcare system, starting with a pilot project in CIS Laval and hoping to develop that across a wide variety of regions in Quebec and beyond Quebec. So I will stop now just to give you some way to contact us if you are interested to learn more. You can follow us on Twitter, and we regularly post tweets about new information. And just to show that the type of knowledge transfer activities we tweet or so, media relations, but also Twitter posts. And we have some visual briefs. So one example is diversity for the LGBT communities and how it's important to take into account their realities, especially when they move to long-term care and they are going back to the closet because they do not want to say that they are from the LGBT plus community. And on your right, you have an example of our visual brief on what are the recommendations for healthcare professionals with regard to non-pharmacological interventions for person living with dementia. So I think that's it. Yeah. Thank you for listening. And now I think it's time for questions. Is it the time for questions?
Yeah, thank you so much, Isabel, Claire, and Nadia for these great presentations. Now I see some questions in the chat. So Fanny, would you mind just unmute yourself and speak to Isabel or others about your questions? Are you still there? Sorry, I think I can.
So Fanny, I can
Fanny?
read what Fanny, the question, is the use of ED and hospital services a marker that is important for person living with dementia and caregiver as it is for healthcare? Okay, I'm scrolling down. Perhaps length of stay or health on discharge or progression of health state is more important. Yeah, that's really a good question, Fanny. So what we heard from our care partners and from the caregivers and the person living with dementia is that it's really stressful to be obliged to go to the emergency department if they have no other choice. And maybe Claire can explain a little bit more what she witnessed in geriatric as well. But yes, it's clearly something they would like to avoid because, you know, there are sometimes person living with dementia are put on contention, for instance, they wait in the corridor and they don't know where they are and they can develop delirium and so on. And it's really stressful. And for the caregiver, it's really a sense of guilt that they need to bring the person to the hospital. And as you have seen, there is a lot of visit to emergency departments for person living with dementia. So it's an important marker for them that we need to study that. At the same time, it's true that what they want to avoid is, and we didn't show that really in this presentation, is to be in a situation where they are in the hospital waiting for a bed in long-term care, for instance, and it has not been anticipated that there is a need to be admitted to the long-term care, among other aspects. So they would like to live well with dementia and to be given a sense of hope and how they can manage their life with dementia. That's why we developed the recommendation on non-pharmacological approaches like physical exercise, cognitive training, anything that they can, healthy diet and so on, anything, they want to know anything that can do to prevent dementia to worsen.
Perhaps I can just say also like that during the work you led, Isabel, during COVID with persons with dementia and care partners. They all, for example, for COVID, one of the challenge in going to the emergency department was that care partners weren't allowed to enter the emergency room, which was like very distressful for both actually, because the persons with dementia was at increased risk of getting delirious, of receiving inappropriate medication because of the delirium. The person couldn't stay where she was supposed to stay, so received medication to calm her down. And at the same time, on the other side of the door is the care partner thinking of all the atrocious things that will happen to their beloved ones. So yes, what we've heard also was a lot of stress around the emergency department visits and the reduced visits of caregivers during COVID.
Thank you. Any comments from Nadia? Okay, we can go to the next question from Samira. And would you mind just unmute yourself, or I can read that for you. Can you explain more about your plan for learning health systems? Nadia, Claire, or Isabel?
Okay, so Samira asked, can you explain more about your plan for learning healthcare system? So we applied to the new call of Living Lab from FRQS recently. And in fact, we have a long-standing relationship with different regions in Quebec, but we were approached by the CIS Laval, who wanted to implement learning healthcare system with us in this region. So our plan is to have a dashboard. I think this is a word in English, but I'm not completely sure. Tableau de bord in French. And to provide them with some indicators that we will select with them. So we have a list of 30 indicators that we can choose from. The most pertinent they feel will help them change their system, plus qualitative indicators, if I may say so, on how the Quebec Alzheimer plan is implemented in their region. So barriers and facilitators and this type of information that they will provide with. And with this information in hand, they want to develop new interventions to complement the interventions that are already in place. For instance, they want to have an intervention on how to better communicate the diagnosis of dementia to persons living with dementia and their caregivers. This work will be led by Marie-Thérèse Lucier, who is an expert in communication between family physician and patients. Another intervention they want to put in place is a navigator. So as the first day of diagnosis, the person living with dementia will be paired with one healthcare professional, a social worker or nurse, who will follow through the disease trajectory and the healthcare trajectory of the person. Because currently, the problem is that we have several case managers managing one person, one from home care, who is a contact person, one from the family medicine group, sometimes one discharge nurse from the hospital, and people are lost because they have so many case managers. So the idea is really to have only one navigator helping them with their healthcare trajectory and health disease trajectory. And so we will evaluate these interventions, see in 2 cycles, see if it's improving the processes. And so Laval will revise what the intervention if it's not improving the processes. And in addition to that, we will have an evaluation of what it is to have a learning healthcare system, what is the overall impact of this type of team combining clinicians, providers, decision makers, patients, caregivers, and researchers together in the same system, the same team.
Thank you so much, Isabel. Alexandra, you have questions?
Yes, thank you. That was great presentation. Now my question is for Nadia, and maybe you mentioned it because I was also distracted by text by the hospital, but in your, the teams, the multidisciplinary team and the not disciplinary team, could it be, how much could you differentiate between the clientele of these clinics? Because often what can happen is that if a patient is very heavy, he ends up being referred to the multidisciplinary team. And we see that often that clinics who don't have, are big groups, they end up with the more simple patients or less demanding. So there's kind of a selection of patient that can happen this way. Were you able to differentiate and untangle that?
Excellent question, Alejandra. So in fact, it's interesting because the way it worked in Ontario is that family health teams were all previously family health organizations. So right from the get-go, these are physicians who just transitioned from being an FHO to an FHT. So even without doing the inverse probability weighting, the patient characteristics were already extremely similar because of the fact that it was already within the same body of physicians, already the same patient population, but with the subset of physicians within this original primary care model, which is just a physician group based, who transitioned to become interprofessional. So when we looked at the patient characteristics, aside from rurality, where we saw some differences there in terms of age, in terms of sex, in terms of income, all of these variants of comorbidity, they were quite already similar at even from a descriptive point of view. The point you raised about could it be that the patients are more heavy in interprofessional primary care? Unfortunately, in Ontario, what was observed, and not just for dementia, but for all populations, is that it was sort of the reverse that happened. So the idea of creating these family health teams was to support complex, vulnerable patients, but physicians who decided to move into this new financing structure, which was more salary capitation based and less fee for service, because of many underlying reasons, what ended up showing up is that patients in family health teams compared to all other primary care models are generally healthier and higher income and higher socioeconomic status. So it had the reverse effect because of the fact that it didn't benefit physicians with heavy patient groups to move into this model of care. And that's why I was very careful in my comparison group not to compare family health teams to a primary care model that's paid by fee for service, because the remuneration method created a lot of confounding in the patient characteristics. So by comparing family health teams to family health organizations, and which were the model that transitioned, I stayed very homogeneous in the patient and physician characteristics. But it's amazing to see how policy and something like remuneration method could have such an impact on who ends up benefiting from that model of care.
Thanks, that's so interesting, actually. Thanks a lot.
Thank you, Nadia and Alexandra. Fanny, would you mind to unmute yourself and just say something about your comments? Thank you.
No, so I mean, Nadia, I was thinking also, like, if these were physicians who had previously been in family health organizations and then they moved to the family health team, you know, I'm not sure if physicians' practices change that significantly that quickly. Like you have to start really using your team members, using the interdisciplinary, working collaboratively with them. So it may also be that that's why you didn't see a difference in terms of the outcomes for your patients.
Thanks, Fanny. That's another really good point, and something that we really wondered about, if there was like a ramp up effect, you know, that the early family health teams might have, you know, we would see like less of an effect, and as the family health teams progressed. But we had from 2002 to 2014, family health teams started in 2002, and that's why we started at that time. And we looked yearly to look at if the effect differed according to time, and it didn't. It was very stable. So it doesn't seem that the ramp up effect of, you know, better functioning teams had influenced these indicators that we observed. Nevertheless, I agree that on the whole, even 10 years in is still quite young for teams to learn how to, you know, roles and responsibilities of team members. And that's why, you know, diving in a little bit deeper in the heterogeneity of teams, I think, is another important next step, and something I'm doing in my research now to look at, were different types of interprofessional teams better than others, you know, ones that had more complete team composition. And in Ontario, one big variability that we couldn't measure is that not all interprofessional team members were co-located. So not just because it was a team, they weren't necessarily physically together. A lot of these team members like OT, PT were traveled from one clinic to another. And so while on paper it's a team, it may not have been necessarily functioning as a team. So there's a lot of heterogeneity in there to unpack. So it's a good point.
Alexandra?
Yeah, on that note, and Fanny, I'm curious to hear what you would think. Do you feel that the residents who are trained in multidisciplinary team are like, you know, using, when they become staff, are they seem to be using more the other professionals than older physicians? Do you think that the age of physician or the age of their training has an impact on how they use the team?
I certainly think that, I mean, all our residents are being trained in GMFUs, so theoretically healthcare teams. How well do the teams really work collaboratively? I mean, that's something else to unpack. I think many of the residents still end up having a very classic model of I evaluate and then I refer to, you know, the specialist or to some other program if it's a home care program. And I think we're still really working on how do you actually work as a team to follow the patient as a team. I'm not sure we, you know, on paper, like Nadia said, often it can look like you do that, but I think, you know, certainly the younger physicians are much more steeped in having other healthcare professionals around them than if you were trained 30 years ago. But I think the desired effect of really collaborating as a team is still developing. They still often work quite separately, you know, in silos. Which is why it's so interesting, Nadia, when you talk about, you know, or Isabel, when you talk about having, who's the point person, who's the navigator? This navigator really has to have relationships and links and collaborate with everyone across all the transitions of care as well, and in different environments, and have really great communication to really be able to get the resources that the patients need. And I think, you know, policies have unintended consequences. And for example, like, you know, the newest, you know, the policy we've had for the last few years where you have to, you know, go through the CRDS to reach a specialist, and it can be anyone. There's not a lot of, you know, cohesiveness. Whereas I think, you know, in the past, you would have your specialist who you would go to, and you would have a relationship. There would be more, you know, communication around your patient's needs. So I think there are many things that will impact on how well that one patient's needs are met.
If I could just say, I couldn't more agree more, Fanny, and especially for patients with dementia, having a relationship of trust with one provider, whoever that may be, is so critical because of their vulnerability in terms of keeping track of who's who and being schlepped around across different team members. So yes, for sure, the team-based approach is theoretically the ideal approach, but we have to make sure that that relationship of trust is maintained, whoever that may be.
Thank you so much. Maria, please.
So thank you to the whole team for presenting this very interesting research. I wanted to come back to the team issue because, Nadia, you raised about teams being sort of virtual teams and not being in the same space. And I think for building up a team, you have to have either a shared space or a pre-existing relationship. It's really hard to develop a team feeling if you don't have either one of those. So I could imagine developing a team of people who aren't necessarily in the same physical space if they've previously worked together and they're sort of comfortable. You know, a lot of what happens in the development of a medical care team is kind of informal communication. And so if you're not sharing a space or you don't have a pre-existing relationship, it's hard to get that going. And I would say, like, in response to your question about the residents, I agree with what Fanny said. And I think a lot of the multidisciplinary relationships are based on being in the same space and being friendly. And so like here at the CLSC Côte des Neiges, we have a couple of fantastic nurses who are always around. So the residents, they're like, oh, I could ask the nurse this, I could ask the nurse that. But if it were a social worker or if it were a pharmacist, it might be that same person. But the important thing is to see the person and to get to know them, to work with them.
Yeah, exactly. And Eva commented on the chat. Eva is one of our former MSc students now, that one of our previous MSc students, he did a review and of what makes an interdisciplinary team functioning, and co-location was one of the key elements of this functioning of the team. And something that we showed in the qualitative studies led by Yves Couturier, who is part of our team. So some aspects that seems quite simple from the outside, like just to know if the person is aware of her or his diagnosis. It's not shared sometimes among the team. So for instance, a social worker receives a reference from a physician, but he doesn't know if he can say, oh, you should go to the Alzheimer Society, or I will help you connect with the Alzheimer Society, because he doesn't even know if the person has been, if the diagnosis has been shared with the person or not. So it seems that it's really complicated to function as a team. And Matt Hacker-Tepper did a really nice review on that, and we can share that if you want.
Thank you so much, Isabel. Any more questions and comments? Okay, so thank you, everyone. Thanks for the team member, and thanks for our participation. And please remind that I would like to remind you that next Friday we will have a special research seminar by our visiting professor Mariana from Brazil. It's talking about evidence for integrated health. So please register here, and we put it in the chat, and we also will send you an email. So thank you very much. Thank you again. Have a nice weekend. See you next time.
Thank you, everyone. Bye.
Bye.